Good evening, everyone. Welcome. My name is Sabiha Gati. I'm a consultant cardiologist at the Royal Brompton Hospital and also work with the ISEH. Welcome to this third ISEH annual conference. This evening, we've planned to cover some pertinent aspects of cardiac care in our athletes. We have an excellent lineup of speakers, two fantastic debates, and I hope you will all get involved with your questions and voting. So without further ado, I'd like to introduce our first session, Too Much of a Good Thing, Cardiac Maladaptation in Athletes, the For and Against Argument, Any Exercise is Possible. This will be followed by a 5-minute rebuttal, and then we will take some questions and we'll ask the audience to vote. So to introduce our first speaker, Dr Aaron Baggish, who needs no introduction. He's a consultant cardiologist working in Switzerland and also known for his past skills as a medical director for the Boston Marathon. He will be speaking on Any Exercise is Possible. Aaron, over to you.
Good evening and welcome. My name is Dr. Aaron Baggish. I am a professor of medicine here at the University of Lausanne in Switzerland, and I've been asked this evening to provide some thoughts about the concept of cardiac maladaptation in athletes and to specifically defend the side of the debate that we should have no worry and that any exercise is possible. Here are affiliations with which I have financial connections as well as active or prior funding sources for my research work. So to begin with, some opening thoughts as they relate to my title, which I was given. Cardiac maladaptation in athletes, no worries, any exercise is possible. So the first thing I want to do is just really dive deeply into the term maladaptation and provide the working definition, which is a causal response to a specific stimulus that confers risk or functional decline. So when we're talking about maladaptation in the context of sport and heart disease, we need to be very clear that what we're talking about is a causal relationship between too much exercise and a heart problem that either increases risk or increases functional decline. The second thing is that I want to be clear that not worrying about athletic maladaptation is not the same thing as not worrying about cardiovascular disease in athletes. I'm a sports cardiologist. I care for athletes with heart disease every day, and this is part and parcel with what I do, and it's the real deal. Finally, any exercise is possible. Well, let's be clear, I would never concede to a blanket term like this, but what I hope to convince you is that in general, more is indeed better. So to start with, where did we start with this discussion? Well, we started with a story that was too good to be true. Many decades ago, the prominent Californian pathologist Thomas J. Bassler published an autopsy case series of marathon runners that had succumbed to traumatic sudden death. And in evaluation of their coronaries, he found essentially no atherosclerotic plaque, wide open, normal looking arteries. And so he proposed that marathon running would confer immunity to atherosclerosis. Now, this story was indeed too good to be true, and we learned this pretty clearly from the RACER study, in which over many years we studied men and women that had died during either half marathon or marathon road races. And indeed, most of the time that sudden cardiac death occurred, it was cardiac in nature, underlying genetic or congenital heart disease. But this event rate was exceptionally low. And importantly, what I want to remind the audience is that the presence of disease in a sportsman or sportswoman does not imply causality. We can't be clear that sport caused the disease. So this myth should not be used as a scare tactic to turn athletes into couch potatoes or even to turn them into more recreational exercisers. I am joined today in this discussion by Thijs Eijsvogels, who's a colleague and a friend, someone I respect quite a bit. And Thijs has written quite a bit about exercise and the heart. And he, in conjunction with Paul Thompson and Barry Franklin, two US-based colleagues of mine, recently published a very thoughtful piece entitled The Extreme Exercise Hypothesis. And this chart here really captures the essence of the extreme exercise hypothesis, which is broken up into two parts, one which is fact and one, as I will convince you, which is fiction. The fact is that when we go from doing no exercise to some exercise, say meeting physical activity recommendation guidelines, we improve our health, we reduce risk of cardiovascular disease, and this reduction in risk is substantial. Where this hypothesis transitions from fact into fiction is where the curve starts to turn upward, and we indeed start thinking about whether too much exercise actually increases risk of disease, eliminating the health benefits of exercise, and actually potentially putting athletes into a higher risk category than those that sit on the couch. And no offense to Thijs, this is a well-written article, but it's just simply not accurate. So when we talk to patients in the clinic about this, and you can take this patient Ted as an example. I use Ted as an example of the masters athlete. He at age 75 has won essentially every competitive rowing regatta in the world, and he's done so with atrial fibrillation, coronary disease. He's done it with hypertension, with a big aorta. And so TED typifies the masters athlete. These are men and women above the age of 35 who exercise vigorously in excess of 5 hours per week, and they emphasize goals. And what you find when you talk to people like Ted routinely is that they sleep better, their mood is better, they have better sex drive, they have better cardiovascular risk factor profiles than their sedentary friends, they have better functional capacity, and they will tell you they have a better life, and indeed they live a longer life. So if Thijs or anyone in the audience is going to tell these individuals to stop this nonsense because you're hurting your heart, we've got to have pretty good reason to do that, and we should be quite clear that any heart risk outweighs that exceptionally important list on the left-hand side of your screen. So of course, Thijs and colleagues are not the first to come up with the too much exercise hypothesis. Probably the most pivotal publication in this space over the last several decades is this editorial that was published in the British journal Heart, Run for Your Life at a Comfortable Speed and Not Too Far, written by two American friends of mine, Jim O'Keefe and Chip Labby. And what they do in this article, and indeed this is still where the crux of this debate hinges, is they look at some epidemiologic data, they review the concept of sudden death during sport, and they talk about some emerging data documenting what we will be talking today about as acquired cardiovascular disease in athletes as a reason to stay away from too much exercise. And indeed, this editorial was picked up by some very high visibility public media syndicates like the Wall Street Journal, who wrote this accompanying piece, One Running Shoe in the Grave. So what I'd like to do is really break down these three lines of evidence, the epi, the sudden death question, and this issue of acquired cardiovascular risk, and hopefully convince you that this article didn't get it right and that we've been barking up the wrong tree now for several years. So let's start with the epidemiology. This is a figure taken directly from the editorial I just showed you. This is a reproduction of a figure that was published in The Lancet. This is an enormous epidemiologic cohort study in which more than 400,000 men and women were followed over an 8-year period. And the interpretation of this curve in the editorial is that above 50 minutes of vigorous exercise a week, that there was a point of diminishing returns, and that you simply above 45 or 50 minutes start losing the benefit and accruing higher risk. Now, perhaps that's an appropriate hypothesis to raise from this figure, but it's just simply not accurate. So here's the actual figure that was published in The Lancet, and this figure received a lot of attention appropriately because it was one of, and still is one of the best exercise dose risk of death and cardiovascular disease data sets we have. But when the authors were pushed to explain why they failed to extend that curve to the same duration that they extended the curve for moderate exercise, they backed up and they corrected themselves. And indeed, they used their data set to extend the curve, and they said that we were not able to identify an upper limit of physical activity, either moderate or vigorous, above which more harm than good will occur in terms of life expectancy benefits. Concerns about too much exercise are more academic than practical, with adverse effect being more short-term than long-term. Our major challenge is how to make the inactive start exercising and not to give them reasons to avoid exercise. And this is one of the major public health problems with this discussion about too much exercise, is that it convinces people to stay away from what is perhaps the most important primary and secondary preventive measure we have in the battle against cardiovascular disease. So there are other studies which raise an eye, and this is one of the most widely cited and one of the most infamous. These are data from the Copenhagen City Heart Study, in which jogging, a surrogate for all forms of endurance activity, was looked at as a predictor for many outcomes here, including all-cause mortality. And what you can see here is that joggers were divided into light jogging, moderate jogging, and strenuous jogging categories, and they were compared to a sedentary referent control. And what you see here, and then this is the clear story that no one will debate, is that when you move from being sedentary toward being a light jogger, so say 20, 30, 40 minutes of jogging several times a week, your health outcomes improve tremendously. What was provocative about this paper is that as we move into the moderate and particularly the strenuous jogger category, the apparent health benefits seem to be erased, and indeed on the lower portion of this figure, which is the fully controlled model, you'll see that the strenuous joggers had a point estimate of risk that was double that of the sedentary control. Now, the figure is striking, but the numbers tell the story. Look at the size of the strenuous jogger group, 36 participants in which 2 had death. And if you look at the confidence intervals around that point estimate, you'll see that there is absolutely no way this can be interpreted with any statistical significance. And I would say probably these deaths were unrelated to cardiovascular disease, which is the topic of today's discussion. So we really have no epidemiologic data to suggest that exercising at high ends shortens your life or increases your risk of clinically relevant cardiovascular disease. Sudden death story is an interesting one, but it's actually much simpler than we're led to believe. So when we see high visibility cases of athletes succumbing to cardiac arrest on the playing field, Christian Eriksen, Damar Hamlin, Fabrice Muamba, but choose your pick, they're out there. The temptation is to say that sport increases the risk of sudden death, and I actually think that's an appropriate conclusion. What I'm showing you here is a schematic which looks at sudden death risk in fit, healthy, athletic people. And what you can see here is they have a baseline of risk in that every time they engage in a bout of vigorous physical activity, their risk goes up, and it goes up quite considerably. So the story here is that if you are going to have a cardiac arrest as an athlete, it's more likely to happen when you're exercising than when you're not. But we can't confuse this with the argument that exercise in general is bad and increases the risk of sudden cardiac death. Because when we go ahead and superimpose the sudden cardiac arrest risk for sedentary people, you can see here that the baseline risk goes up by a factor of 5. The area under the curve is 5 versus 1, which means that their overall risk of cardiac death is almost 80% higher than physically fit people. So this is an area under the curve story, and this is one that the exercise naysayers absolutely love to get wrong. They look at the spikes but forget about the baseline risk, and so we should not use sudden cardiac death as a reason to scare our patients away from too much exercise. Let's transition now to talk about the concept of acquired pathology. And what we're talking about here are a list of diseases or phenotypes, if you will, that have been associated with too much sport, more specifically phenotypes that have been seen in competitive athletes. So let's start with atrial fibrillation. And I will concede that there are a number of well-done observational studies which all reach the same conclusion, and that is that men and women, particularly men, who push their bodies hard into the 4th, 5th, and 6th decades and beyond of life are at increased risk of atrial fibrillation. This is clear, this is not debatable. Perhaps the best of these studies, and one of the most illustrative, comes from Sweden, in which participants in the Vasaloppet, which is a 90-kilometer annual ski race, were followed for a 10-year period of active race participation and then through a clinical surveillance initiative. And what the authors did, which was quite clever, is they looked at 2 things. They looked at the speed with which these men raced, so their race time, and they looked at the number of races during the study period. And they used race time and number of races as surrogates of exercise intensity and exercise volume, and indeed show that both volume and intensity were predictive of arrhythmia, and AFib was the dominant rhythm issue. So why do athletes get AFib? Kind of the classic explanation is that this is a function of cardiac remodeling and that roughly 20% of athletes have left atrial enlargement. So if you borrow a lesson from the heart failure world, perhaps a big left atrium is the explanation in competitive athletes. And while I will certainly admit that there are a host of sport physiology specific things, left atrial dilation probably less so than fibrotic remodeling, but changes in the autonomic nervous system, intermittent left atrial hypertension during exercise, inflammation, genetics, these are all real, and these are probably part of the pathophysiologic cascade. But what we forget about is not so much the things that happen during sport, the things that may come along with the sporting lifestyle. Alcohol consumption, illicit substance abuse, caffeine excess, psychosocial stress. And these are things that always get left out of the discussion about why masters athletes have AFib. So what we can conclude is that indeed endurance athletes are at increased risk of fib, but how much of this risk is explained by sport physiology versus non-sport lifestyle factors? In clinical practice, you find these non-sport lifestyle factors all the time. And so my message is don't tell people to stop the sport. First, just address the non-sport issue. And besides, is AF, which is really an imminently treatable condition, a reason to tell people to reduce or cease high levels of exercise? I'm not so certain, and that's certainly not how I practice. So Thijs today will invariably tell you the troponin story, and it's an interesting one. And there are 2 bookends I want to share with you, both of which come from his work and some work that I've collaborated on him with. The first was a study that Thijs did with me when he was in training and spending time in Boston, in which we looked at troponin release among runners of the Boston Marathon. And what you can see here is that among the 80 or so runners we studied, all of them leaked troponin. Now, some of them leaked more, some of them leaked less, but all of the runners experienced an increase in troponin I. And so we concluded in this publication, and I think appropriately so, that exercise-induced troponin is a ubiquitous finding among recreational marathon runners. Now, what was missing from this study were outcomes data, and perhaps the most infamous outcomes data set that we have with relate to troponin, again, work done by Thijs, comes from the Nijmegen 4-day Marches data set, in which individuals that had the more robust troponin releases were indeed those with cardiovascular disease, and they were also the ones that had the poorest survival. And while this is not in any way debatable, that if you take older people with coronary disease and exercise them and they bump troponins, they're not going to do as well as younger fit athletes that either have lower troponins and or who have no cardiovascular risk factors. But before we actually insert this data set into a discussion about high-level exercise, just take a look at the people that were studied in this. These were well-to-do walkers who traveled from all over the world to walk for 4 days, either 30, 40, or 50 kilometers. And this field was undoubtedly sprinkled with people that had underlying heart disease. And so, of course, troponins were leaked at high levels. And of course, those that had the troponin leaks didn't do well in follow-up. This is not a story of athletes. And so the troponin story as it relates to our competitors is don't test it, don't think about it. Think about these people as healthy and stay away from the blood work. What about the issue of fibrosis? So most of you are familiar with this important study from André Lagersh and colleagues, which was done in Belgium now, more than a decade ago. And what André and his colleagues did is they showed that in a group of 40 high-level endurance athletes, there was evidence of focal fibrosis in 5 of 40. They also put forth a very nice pathophysiologic explanation in the form of stress on the interventricular septum. But the question I want to ask about this fibrosis story is, if sports are really causal, why was fibrosis found in only 5 of the 40 athletes? And again, how common and relevant is this truly alarming entity in real clinical practice? So the answer to this, from my perspective, is that it is not just sport itself. Certainly, if you exercise at very extreme volumes and intensity and fail to rest enough, so a training recovery mismatch, and or if you have something at your genetics which confers host susceptibility, and it's not the ARVC genes, those have been vetted, it's something we still don't understand, or perhaps more importantly, there's some secondary process like illicit drug use, occult infection, or something as simple as uncontrolled hypertension, that it's possible to have a perfect storm in which your heart ends up like this. However, we are now a decade out from this study, and I think the absence of any further data to show that this is truly a problem with clinical relevance makes it pretty clear that exercise alone is very unlikely to be the problem. And what we still don't know is when and if we find this, what are the things that go into it? It's almost certainly multifactorial. And truly, is there any clinical relevance? I suspect probably very little, and if so, that remains to be seen. So let's finish with coronary disease in the last few minutes. You're all familiar with this study, 2008 European Heart Journal. A group of German marathon runners were compared to age match and risk factor match controls and put through the CT scanner to look for coronary calcium. And indeed, the men that had the highest calcium went on to have events that we as cardiologists care about, and so the calcium score was predictive. And let's just think about who these men were. First off, these were real marathoners, 22, 65, 140 marathoners, and they had bad things to happen to them. VT during exercise, stent cabbage, stent. But when you look at who they were going into this study, dyslipidemic, uncontrolled hypertension, former smokers, this is not a function of too much exercise. This is a function of cardiovascular risk factors. So the logical next step, and this was done, was to try to recruit athletes that were so-called risk factor free. And these are 2 tandem studies that were published in Circulation several years ago. They both reached basically the same conclusion, and that is athletes do tend to have more coronary plaque, but it's largely calcified plaque, and that this was probably, although we didn't and still don't have good outcomes data, not a particularly malignant clinical phenotype, but more of a remodeling / protective effect. Now, this was challenged recently by data that were presented at the American College of Cardiology scientific sessions in March of this year. These are data from the Masters Heart Study. And for the first time, we have a Masters athlete cohort in which indeed there was more coronary disease than there was present in sedentary controls. And this time it was not only calcific disease, it was non-calcific disease. So this is provocative and raises the issue about whether or not true clinically relevant coronary disease, because again, it's the non-calcified plaque we worry about, is relevant and suggests it might be. But as I said in an accompanying piece on this, rather than simply blame too much exercise, we've got to be asking about the unmeasured confounders: genetics, psychosocial stress, dietary choices, people's carefree 20s and 30s, meaning what they did before they became athletes, and a sobering reminder that no matter what a picture test from a CT scan shows, we simply have no data to suggest that high amounts of exercise increase adverse disease outcomes. So to finish the coronary disease story, I want to just put this into context for you. On one end of the spectrum, we have guys like Johnny Kelly, multi-time winner of the Boston Marathon, whose autopsy showed widely patent, perfectly normal coronaries with salt and pepper calcification. On the other end of the spectrum, we have men like this who succumb to truly clinically relevant coronary disease, and this is because they typically have risk factors that they fail to address appropriately. So in clinic, we exist along a spectrum from benign to lethal, and I would tell you that the benign phenotype, which is the most common in true high-level exercisers, is not the one we should be worried about. But what we do need is better tools in the clinic to resolve this spectrum. And until we have these tools, stop looking for CAC and don't use it as a scare tactic. So what I've hoped to convince you of is that the epidemiologic sudden death and acquired cardiovascular risk factors are no reason to steer people away from exercise. And fortunately, Thijs agrees with me. The conclusion of his exercise hypothesis paper is that there are limited evidence to support the extreme exercise hypothesis. Sure, atrial fibrillation exists and we need to treat it and understand more why it happens, but that the cardiac anomalies that we really care about clinically are the small minority, and known or occult atherosclerotic cardiovascular disease seems to be less about exercise and more about the risk factors that men and women bring to exercise. So with that, I will conclude, and I very much appreciate your attention.
Right, thank you, Aaron, for an excellent talk. I'd like to introduce Dr Thijs Eijsvogels, who is an exercise physiologist from the Netherlands and has also been pivotal to the work, our knowledge in cardiac adaptations in athletes. He will be speaking against any exercises possible. Thijs, over to you.
My name is Thijs Eijsvogels, and today I will be lecturing about cardiac maladaptations in athletes and why we should be worried. So exercise is a very potent medicine as it reduces the risk for numerous chronic diseases from a primary and also secondary perspective. As you can see here, it lowers the risk for cardiac diseases, pulmonary diseases, it improves your skeletal muscle strength, bone health, reduces cancer types, and so forth. But today's question is actually, can you do too much of a good thing? And that's what this debate is about. And I will argue that we can actually do too much of a good thing. So let's have a look at the data. Here is the dose-response relationship between physical activity and cardiovascular risk. And it appears to be a curvilinear relationship. But if we take a closer look to this association, it appears to be that the health benefits of increasing your exercise volumes are mainly at the beginning of the curve, as been shown here. So if you move from an inactive lifestyle to a life with some activity, there is a substantial reduction in the risk for cardiovascular diseases. But if you're already more active and you increase your activity level to a similar extent, then you can see that the health benefit associated with this change is already smaller. Let alone if you're somewhere here, then you can see that increasing your activity volume hardly has any benefits. The thing is actually that more and more people engage in extreme exercise events or mass participation exercise events, such as long distance walking, cycling, uphill cycling, marathons, ultramarathons, and even Ironman triathlons. And then the question is this dose-response relationship curve complete? Or is there missing a part? And those who do the most exercise, what is their cardiovascular risk? And actually, some studies show or suggest that there will be a diminished health benefit associated with such extreme exercise volumes. And this is being known as the extreme exercise hypothesis. And I will share some data with you today that will support this extreme exercise hypothesis. So let's have a first look to population studies. This is a very elegant study which was published in 2015, and it uses data from different cohorts from the United States, but also from Europe, and it has an impressive sample size of over 600,000 individuals, which were followed for more than 14 years. And what you can clearly see in this dose-response relationship is that compared to the reference group of physically inactive individuals, those complying to the current guidelines of 150 minutes of moderate to vigorous exercise per week, you can see this was associated with a 30% risk reduction. The optimal dose group were those individuals that actually performing 3 to 5 times the recommended exercise volumes, and they benefited from almost a 40% risk reduction compared to the reference group. However, those doing more than 10 times what is recommended, you can see an uptick again in this curve, and they only had a 30% risk reduction. So actually, they did worse compared to the optimal group. And although the confidence interval is wide because only few people were in this group, I think this is a very nice illustration that there is actually that you could do too much of a good thing. And this is not the only study, because also other studies have shown the same dose-response relationship. This is data from the Cooper Clinic, more than 50,000 individuals, 15 years of follow-up, and basically you can see the same pattern here. So if you have a very low running distance, less than 6 miles per week, you do very well. If you run less than 3 times per week, you do very good. But if it's towards the extreme end and you run every day, then you see a complete loss of the health benefits associated with your running habits compared to the inactive group not running at all. So there are several potential detrimental effects of exercise on the heart that could explain this extreme exercise hypothesis. First of all, this is sudden cardiac death, which you all know that can appear at vigorous intensity exercise. There is also some studies in that look at cardiac dysfunctions, which is present, for example, immediately following a marathon, but typically recovers within 24 to 84 hours post-exercise. There are many studies showing that cardiac biomarkers are basically released during and immediately following exercise. Some studies even show that exercise could induce a cardiomyopathy. And there are reports that myocardial fibrosis is more prevalent in athletes compared to controls. And the same is true actually for coronary atherosclerosis, arrhythmias, and even some studies suggest that there is an attenuated life expectancy in the most active individuals. If we take a look to this overview, then you can clearly appreciate that on the left side are more the acute effects of exercise, whereas on the right side of this illustration, these are the long-term effects. And today I don't have the time to cover all those topics, but I will focus on the most important acute as well as long-term effects. So let's start with troponin release first. Troponin is a biomarker that can be easily assessed in the blood, and we know that exercise produces elevations in cardiac troponin levels in everyone. This is data from the Boston Marathon, and I collected this data together with Dr. Baggish, and here you can see individual data of our study cohort, a little over 70 participants, and you can see that every individual, so every bar, represents an increase from pre to post marathon. We also looked at factors that are associated with the magnitude of this increase that we typically observe in athletes following a marathon run. And here you can see them, for example, age, exercise intensity, duration, some environmental factors, cardiovascular health status, but also training experience, blood pressure, and sex. But among all those factors, exercise intensity and also exercise duration are the most prominent factors that drive this exercise-induced cardiac troponin release. On the other hand, we see that the kinetics of those biomarker release are markedly different from what you typically see in patients. So in those athletes, you see that there is an immediate increase during exercise and up to 6 hours post-exercise. But from 7 hours post-exercise onwards, you see already normalization with complete normalization within 1 to 3 days, basically post-exercise. Furthermore, it's also important to note that none of those participants had any physical or clinical complaints associated with this troponin release. So for a very long time, it was believed that this was actually a benign phenomenon and we shouldn't worry about exercise-induced troponin release. On the other hand, if we look to clinical data, it appears to be time after time that troponins are a very strong predictor of adverse outcomes. And this is data from a clinical cohort. There are patients with chest pain at the emergency department, over 20,000. And here you can again see a very clear dose-response relationship. Those with very low troponin values, less than 5 nanograms per liter, they have a very good prognosis and low probability of all-cause mortality during 5 years of follow-up. But then even in the normal range, so those with 5 to 9 nanograms per liter or 10 to 14, they have a poorer prognosis compared to those with the lowest value. And if you actually exceed the 99th percentile, you see that again there is a stepwise increase in the risk associated with those troponin levels. Also, studies from the general population confirm this relationship between resting troponin concentrations and outcomes during follow-up. This is a population study, more than 60,000 individuals. And again, you can see here on the x-axis the troponin concentration and on the y-axis the hazard ratio, which has a curvilinear increase with a greater risk at higher troponin concentration. So the question is really, can those findings be extrapolated to athletes, or is something else going on? Well, to answer this question, we've set up a study during the Nijmegen Marches. This is the largest walking event in the world with over than 50,000 participants, and we were able to enroll 725 of them. They walked 30 to 55 kilometers on a single day, and they needed about 8 hours to cover this distance. And during follow-up, 29 of them died and 33 experienced a major adverse cardiovascular event. And this is how it looked like for those with a low troponin concentration, so below the 99th percentile or the upper reference limit, compared to those exceeding this clinical cutoff. And here you can clearly see that those with a high troponin post-exercise did worse compared to those with a very low troponin. Also, if we correct for all kinds of confounders, it appears to be in the fully adjusted model that an elevated troponin post-exercise was associated with a greater risk of mortality and MACE during follow-up. So based on those findings, we cannot say anymore that exercise-induced cardiac troponin release are an entirely benign phenomenon, because they hold prognostic value, and the higher the troponin value post-exercise, the worse the prognosis. Another interesting topic of interest is coronary atherosclerosis. And not so long ago, it was even suggested that if you were able to complete a marathon, then you would be immune to atherosclerosis. Unfortunately, this Basler hypothesis is not true, because now we know from many studies that this is actually not the case. And these are the studies that I'm referring to. They have been published in the last decade. They are from multiple countries. So the first study was from Germany, and then follow-up studies from the Netherlands, the UK, and the US. And basically, they show all the same data. So what they found is that a high calcium score, which is a marker of coronary atherosclerosis, was more prevalent among athletes versus controls. And within the athletic population, there was even a kind of dose-response relationship depending on the lifelong exercise dose, but also the intensity level of their exercise training. And here you can clearly see that for every of those studies, the most active group had the highest prevalence of a high calcification score. The problem of those studies is that they were all cross-sectional or even retrospective. So from that point of view, we performed a prospective study, and in this study we were able to enroll nearly 300 athletes with 6.5 years of follow-up. We made CT scans for assessment of coronary atherosclerosis at baseline and follow-up, and here you can see what we found. So for the calcium score, we actually observed that there was an increase during follow-up, and after 6.5 years, the percentage of the population exceeding 100 Egerton units was doubled, and we even had 6% of the population that had a calcium score greater than 1000. We also assessed whether this change in calcium scores was mainly due to exercise volume or to exercise intensity. And from this figure, you can appreciate that especially very vigorous intensity exercise really was the driver of this accelerated calcification that is typically observed in athletes. So this was a remarkable finding. And again, because it was exercise intensity, it really shows that you could do too much of a good thing. So why is this important? Well, there are many population-based studies, but also clinical cohort studies, and they show time after time that higher calcium scores are related to a worse prognosis, both from a cardiovascular disease events perspective, but also non-cardiovascular disease events, as been shown here. Of course, if you're physically active and you do regular exercise, it impacts the risk associated with this calcium score. But in this study, you can again clearly see that a calcium score of 0 is very good from a prognostic point of view with little events. But as soon as your calcium score increases, it also increases the event rate, all-cause mortality in this study. And although the most active individuals, they have fewer events than those who do not exercise, they still experience events. So it's not that being an athlete, and if you have a high calcium score, that you're protected from any events during follow-up, because still those panels, panel B and panel C, clearly show that also the most active individuals experience events during follow-up. Another important thing is to look at the phenotype of the plaques, because the initial study, and that was the Dutch study, but also the UK study, they've shown that calcified plaques were more the dominant type of plaques in athletes, and they had fewer mixed plaques. And this concept was basically challenged by a recent study that was published from Belgium. They had a large cohort of controls and athletes, and basically what they found is again that plaques were more common in lifelong athletes compared to controls. But when they looked at the type of plaque, it appeared to be that there was not a difference between calcified, non-calcified, and mixed plaques across the three groups. And this really challenges the previous observations from the Dutch and the UK cohorts. And this is important because plaque type or plaque phenotype is also being linked to different risk estimations during follow-up. And here you can see the three different types of plaques in the clinical population, and you can clearly see that calcified plaques were the stable plaques with hardly any events during follow-up, but mixed plaques, they were more vulnerable. And if it is really the case that this is the same for athletes than for inactive controls, then it seems that doing this high volume, high intensity exercise training doesn't protect from coronary atherosclerosis, and potentially also not from his clinical events during follow-up, but this has to be investigated in future prospective studies. So the last thing that I want to address are arrhythmias, because there is many evidence that atrial fibrillation is more common in athletes compared to sedentary controls. This is a very nice study from Sweden looking at participants of the Vasaloppet cross-country ski race, and during almost 10 years of follow-up, they observed a kind of dose-response relationship between the number of race participations and the prevalence or the risk of atrial fibrillation during follow-up, with more AFib in individuals participating 5 times or more in this ski race. What was interesting is that they also linked this to stroke, because that's one of the risks associated with AFib. And here you can clearly see that skiers with atrial fibrillation do better than non-skiers with atrial fibrillation, but they do worse than non-skiers without atrial fibrillation or skiers without atrial fibrillation. So from that point of view, if you have a greater risk to develop AFib as a lifelong endurance athlete, it only protects you partially from the clinical events associated with this condition, and it's not that you have the same risk as skiers without AFib. And I think this is a very important observation. So in summary, I think there are multiple lines of evidence supporting the extreme exercise hypothesis, because we observed a reverse J-shape association between exercise volume and mortality in multiple epidemiological studies. We also know that exercise-induced troponin release strongly depends on exercise intensity, and we've shown that it's predictive of clinical outcomes in long-distance walkers, and those findings now need to be validated in other type of cohorts of endurance athletes, such as cyclists and runners. Furthermore, cardiac maladaptations such as coronary atherosclerosis and atrial fibrillation are more common in athletes versus controls, and they also again strongly depend on the amount of lifelong exercise volume and also the exercise intensity on what they train. Finally, a physically active lifestyle may attenuate but not nullify the health risks associated with these deleterious adaptations. So that's why we should worry, and that's why you cannot exercise at all levels, and maybe moderation of exercise habits is key to benefit the most from your physically active lifestyle. Thank you for your attention.
Thank you to excellent speakers. We have with us Vincent Aengevaeren, a postdoctoral researcher and a cardiology resident who works with Thijs, who stepped in to do the rebuttal on Thijs' behalf. Welcome, Vincent. So I'd now like to give the stage to Aaron. You've got 5 minutes to do your rebuttal, and then we'll move on to Vincent for his rebuttal. Over to you, Aaron.
All right, thank you. I don't think I'll need all of my 5 minutes, but here's what I think. So let me start with acknowledging some of the things that I think Thijs and Vincent and I would all agree on, and there were some points in common in the talk. First of all, exercise and even high doses of exercise are an incredibly potent form of medication, right? They basically make every single type of disease that we try to treat, perhaps with the exception of AFib, better. So again, when we're talking about treating cardiovascular disease from a primary or secondary preventative perspective, exercise is the magic bullet. Second thing I think we can agree on, though, is that there's diminishing returns. So that when you go from being sedentary to doing some exercise, your return on investment is the highest. And as the exercise dose continues to tick up, you get less and less return on improving cardiovascular risk factors, increasing longevity. So there almost certainly is an asymptote to how much benefit we get from exercise. But decreasing benefit does not mean increasing harm. So Thijs and I showed a lot of the same studies, but we just see them through a different lens. And there is not a single study I'm aware of that shows this uptick, or this so-called U-shaped curve in which the highest amount of exercisers actually reach a statistically significant increase in problems, right? Sure, in that group of people that push their bodies hard, there may be those that bring cardiovascular disease to the equation independently of their exercise, and they may have worse outcomes than more moderate exercisers that are truly completely healthy, but we can't look at those studies, none of them. We can't look at any of these studies and say that there's a statistically significant increase of bad things happening in those that push their bodies the highest. So I think we agree on that. One of the most important problems in our field, and this came through loud and clear in Thijs' talk, is the use of general population lessons to inform us about how we think of the highest level athletes and the fittest people. Look, how many times do we have to get this wrong, right? We learned that left ventricular hypertrophy, which is predictive of bad outcomes in the general population, has nothing to do with outcomes in athletic population. We learned that ECG changes, repolarization abnormalities, are no good if you're a sedentary couch potato or a recreational exerciser, but in many cases, they're actually a function of the type of athletic activity that some of our fittest people do. So we've seen this story play out over and over again, and this is the same problem with the troponin argument, and it's the same problem with the coronary calcium argument. There is not a single study I know of, aside from this crazy March study, in which people have bad outcomes associated with exercise-induced troponinemia. And again, let's be clear, as I said in my talk, if you take a large group of older people many of whom are not fit elite athletes, but people that simply want to go out and walk for a couple of days. You got a lot of people in that group that probably have subclinical coronary disease. And of course, if they walk and do much more than they're used to on a regular basis, they're going to have ischemia. They're going to leak troponin, and those are the ones that you're going to see in your cath lab at some point down the line. That is not an argument that applies to the fittest and the highest levels of exercisers. That's, again, a general population being put into a non-general population situation, and the missed message there is quite clear. The next thing I want to address is this issue of prospective studies. You do a prospective study of athletes with coronary calcium, and guess what? You're going to see more calcium over time. You do the same study in people that are being given a statin, and you're going to see more calcium over time. Coronary calcification is a non-specific indicator of repair and recovery. So indeed, if the arteries are stressed or the arteries are exposed to a medication that turns soft plaque into hard plaque, you see more calcium over time. Until we see a study that definitively shows that higher levels of calcification mean something clinically, again, I would encourage people to stop checking coronary calcium in their athletes and to just leave this alone. And again, just to finish, I want to remind everyone about this issue of unmeasured confounders. When we see papers that purport to study athletes that are low risk, we have to look at the factors that went into that calculus. And indeed, controlling for cholesterol, controlling for diabetes, controlling for tobacco use is important, but all of the unmeasured confounders which truly delineate risk in this group, so again, things like psychosocial stress, dietary changes, the lifestyle they led for decades before they decided to become high-level athletes, these are the reasons we see these people in clinic get into trouble. And when we do so, it's not a reason to blame the sport, it's a reason to remind them that the things they brought to the sport were the problem. So with that, I'll turn it over to Vincent. I very much appreciate everyone's attention. This has been a great debate.
Thanks, Aaron. Vincent, over to you.
All right. So Thijs left the hard stuff for me. Yeah, so I think we can all agree on that Dr. Baggish and myself, we think about things the same way for a lot of things, but I would like to highlight several things from his presentation to indicate that not any exercise is beneficial, which is really the topic of the debate here, because I think we of course we all agree that exercise is healthy, but it's really about, can you do too much? And I think already in his first slide, Dr. Baggish indicated that in fact you can do too much. And I think that the comparison with a sedentary control group for some of the studies is of course not really the case. The question is really, if you do even more than a lot, does your risk increase or do the benefits diminish? And I would like to give you a couple of statements to think about before I give a little bit of the rest of the explanation. So would you rather have no plaque in your coronary arteries or have some plaque? Would you rather have a low coronary calcification score or a high coronary calcification score? Would you rather have no myocardial fibrosis or any myocardial fibrosis? Would you rather have no atrial fibrillation or any atrial fibrillation? And would you rather have an increased chance of dying suddenly during exercise or not? So, and would you rather have a low troponin following exercise or a high troponin? So for me, it's all the first. So I'd rather have low risk. And of course, there's no real, for not everything, there's definitive answers in studies showing the increased risk, because we just don't have the studies yet. And if I start with troponin, so indeed, the 4 days marches, those are more a general population, not the most fit athletes. But even after adjusting for several confounders and sensitivity analysis and only in the healthy group, you saw the same trend that higher troponin was associated with increased risk. So that it was just individuals with cardiovascular diseases, at least not typical known cardiovascular diseases. That's not really the case. And of course, it's different if you look at marathon runners. They have a lot higher troponin increase, and of course, the concentration at which risk might increase will be different. But just because we haven't done the study yet, does that mean that there's no potential increase in risk? For 25 years, we also thought that a high troponin was not associated with increased risk. And when we did the study, we first showed that it was the case. And of course, the epidemiological studies, yeah, the uptick in all the population studies, it's non-significant, and it's also mainly because not a lot of very active individuals participate in those population studies, which is of course a problem. But maybe if we have larger and larger studies, finally we could see something. If we look at the coronary calcification, I think everyone is clear in the data that we see increased coronary calcification. As Dr. Baggish adequately addressed, we have no outcome data on that. However, in the Cooper clinical longitudinal study, they do have also people from the general population who are very active. And in active individuals, you also saw that those with a higher coronary calcification score had a higher risk than a lower coronary calcification score. So, I mean, even in very active individuals, a higher calcium score is associated with a higher risk. So, are you really going to take the risk of having a higher coronary calcification score? And for atrial fibrillation, like Thijs also showed in his presentation, with atrial fibrillation also in athletes, you have a higher risk of stroke. Even though that risk is not as high as a non-athlete, you still see increased risk of atrial fibrillation. So also, I'd rather have no atrial fibrillation than atrial fibrillation. And of course, we definitely need more outcome data. But I have to say, we're working very hard on that, and hopefully Dr. Baggish will also collaborate with us to get more data to support this debate in the future. And that was pretty much what I wanted to rebuttal on.
Thank you, Vincent. Both excellent rebuttals. I hope the audience are voting for or on against. So I have a question for you both, actually. So there are some studies that have shown up to 100% of individuals get an elevated troponin post-endurance event, even if it doesn't exceed the normal threshold. So how do we put this into context for our audience? You know, what are the ones that we should be worried about? Perhaps Aaron, you want to take the question first?
Sure. Well, I can kind of go back to the experience I have had over many years at the Boston Marathon, where we were doing troponin testing for some time as part of our routine unwell runner assessment in the tent. And we found high troponins in everyone. But just as any clinician would know, your pretest probability of interpreting a test is based on clinical factors that you don't get out of a blood tube. So it's the people that come in with chest pain, the people that come in with oxygen hunger, the people that come in with altered mental status that might look like cardiogenic shock. Those are the ones we care about. And I would submit you don't need a troponin level to be worried enough to send them to the hospital and get a coronary angiogram, because they're the ones that have an acute coronary syndrome, but they're few and far between.
And Vincent.
Yeah, so it's really the problem. We do see an increase, and especially in the marathon runners, you can see quite high troponin levels. And currently, we're not sure yet how to deal with that. So I totally agree to only do that in a research setting, generally, or a true clinical indication to do such a thing, and not in generally healthy marathon runners as a routine practice. And so I don't think we really have the cutoff value for when you should worry. I don't know we really have that in normal individuals yet, and especially not in an acute situation. So I think we really need more research for that.
Okay, perfect. So another question from the audience: if one builds up exercising gradually from being sedentary, is this less likely to cause cardiovascular damage versus if one immediately begins with vigorous exercise?
Want to go first on this one, Vincent, and I'll follow?
Yeah, so I think that there's a nice paper out on that that the acute risk of exercise is pretty much dependent on your habitual frequency of exercise. So that's so if you don't do a lot of exercise and then start exercising strenuously, all of a sudden you have a higher risk of getting a cardiovascular event in that period. So and that's also pretty much a basis for building up slowly. So I would say yes, if you go from 0 to 100 very quickly, you have a higher risk of cardiovascular events during exercise.
Okay. One other question I have for you both. So what advice am I giving my asymptomatic athlete with severe calcified coronary disease based on the evidence you've both presented? What do I do with that athlete in clinic?
Well, let's be clear. Once you have that information, you're obliged to take it one step further and to do an evaluation for obstructive coronary disease. So it's not clear to me why an asymptomatic high-functioning athlete would go through a coronary scan, but once you have that information as the attending cardiologist, it's your job to exclude obstructive disease. And that could be as simple as a good history coupled with an exercise stress test. Some people would advocate for a coronary CT angiogram, which is reasonable, but the job is to exclude obstructive disease. And then at that point, my practice is to tell them not to change anything they're doing.
And Vincent, how would you manage? How do you manage these individuals?
Yeah, so pretty much the same. So when individuals already have a very high coronary calcification score, the CTA is pretty difficult due to blooming artifacts. So usually you do a functional test to exclude ischemia, which could be an exercise test or a imaging stress test. And I always prescribe them statins, and depending on the risk associated. So it really depends on the clinical situation and how high the calcium score is. But that's definitely something to take into account. Also, for extremely high calcium scores, you have to consider aspirin as well. There are some studies suggesting that over 100 you already would have should consider aspirin, but I think that's a pretty low cutoff.
Perfect.
Sabiha, can I make one further point? I just wanted to go back to the really important question that Vincent was asking about. Would you rather have calcium or not? Would you rather have a little fibrosis or not? And of course, I think the answer is you'd probably rather not have those things in isolation. But to me, the more important question is, would you rather have a little bit of fibrosis or a little bit of coronary calcium and a robust level of fitness and high peak oxygen consumption, which we know beyond a shred of doubt is a better predictor of how long and how well people live than anything we can measure with a picture-taking test or a blood test. So I would be more than comfortable trading off a little calcium in my arteries or trading off a little fibrosis at my RV insertion hinge point if my peak VO2 is 60 mils per kg at age 60, because I know those things aren't going to kill me and I'm going to live longer than the people that have no calcium or no fibrosis that are sitting on the couch.
I totally agree with that. But unfortunately, my VO2 max doesn't increase that easily by 10 to 20 points. But my calcium may.
Lovely. Right, let's see.
And what I wanted to say, one thing that what was important, what Aaron also said, is like to treat risk factors really aggressively in those individuals. I mean, I do get a lot of people who have like a lot of athletes who have untreated risk factors, because people then say, oh yeah, they're fit, you don't need to treat the risk factors, you can allow much higher values for blood pressure, cholesterol, etc. I mean, definitely in those individuals, it's also good to treat risk factors to lower cardiovascular risk in the long term.
So we've got lots of questions coming in from the audience. So another question is, should one screen an athlete to get a calcium score before exercising if there's a strong family history of coronary artery disease?
So it depends on who the athlete is. If we're really talking about an established high-level exerciser, I would not bother doing a calcium score because you're probably going to find calcium and you're not going to know what to do with. If you're talking about a sedentary person who's choosing to become athletic, this is a general population question. This isn't a sports cardiology question. So if you think they have risk factors and you want to convince them to get on a statin, do a calcium score. But that's not the same thing as looking at whether or not sport caused that calcium.
Perfect. Another question we have is, exercise can cause a raise in troponin. Can SVT cause a rise in troponin?
Yeah.
No question.
Yeah, perfect. I think we should get the results in now and see how our audience have voted for either for or against any exercises possible. So let's have a look. We've got 57% for and 50% for against. I think the battle was equal from my perspective. Well done to both speakers. Excellent talks. Thank you very much, both of you. Okay, so we're going to have a short break and come back at 8 p.m. for another excellent debate, the fight between David and Goliath. I hope I will see you all there very soon. And yeah, look forward to the next debate. See you very soon. Welcome back, everyone. So we're going to start off with the second debate on the fight between David and Goliath. You can decide for yourself who is David and Goliath. We are going to talk about moderate aortic regurgitation and normal ejection fraction. The House believes that any exercise is possible, the for and against argument. This will be followed by a 5-minute rebuttal from each speaker, and then we will take questions and ask the audience to vote as to for or against. So I'd like to introduce our first speaker, Dr. Gerardo Finocchiaro, who is a consultant cardiologist who worked with me at the Royal Brompton and has now moved on to St George's Hospital. And he again has published extensively in the field of sports cardiology. Gerardo, over to you.
Thank you very much for the invitation. My name is Gerardo Finocchiaro. I'm a consultant cardiologist at St George's Hospital in London. Today, we're going to discuss about moderate aortic regurgitation and normal ejection fraction. Is any exercise possible? And the answer to this question is quite straightforward and easy. It's yes. So I would like to start from the European Society of Cardiology guidelines on sports participation. And particularly, we will focus on aortic regurgitation. We see that aortic regurgitation is classified as mild, moderate, and severe. For the topic of today, we're going to discuss moderate aortic regurgitation. And we see that guidelines suggest that participation in all competitive sports, if desired, should be considered in individuals with LVF more than 50% and normal exercise test. We see that the class of recommendation is 2A and the level of evidence is C. Just as a reminder, class 2A means that the weight of evidence and opinion is in favor of efficacy. Level of evidence C means that there is a consensus of opinion of experts or small studies, retrospective studies or registries, no randomized controlled trial. And indeed, there are no randomized controlled trials, as we will see in the next few minutes, that would help us in answering these questions. However, I think we can try to speculate on some studies that have been done and trying to go back to pathophysiology and try to answer these questions. So, as a general thought, why an athlete with a cardiac condition should not compete? Well, mainly for two reasons. The first is because intense exercise may trigger serious arrhythmias. And the second is because intense exercise may worsen the underlying condition. So, starting with the first, is aortic regurgitation an arrhythmogenic disease? Well, I would like to take you to this study published more than 30 years ago on Circulation. This is a study on severe aortic regurgitation, so it's something worse than what actually we are discussing today. 104 patients with severe aortic regurgitation, indeed, asymptomatic, followed for 8 years. The authors found that 2 patients died suddenly. And they describe the characteristics of these 2 unfortunate patients. We see them on the right. We see that these 2 patients had a very severely remodeled LV myocardium, an LVDD of more than 80 millimeters, and an LVF, which was reduced, was less than 50%. So clearly, the message is that true, sudden death can occur in severe aortic regurgitation, but it occurs mainly in individuals who have a severely remodeled myocardium. We can take also a slightly different approach. We can look at a autopsy series of athletes who die suddenly. And I would like to show you today 2 series from our group at St George's Hospital, and 2 American studies from Dr Aaron's and Dr Harmon's, 2 actually US registries on young athletes. And we see that the results are slightly different because in some studies there is a prevalence of sudden arrhythmic death syndrome, so normal heart at a post-mortem. In others, there is a predominance of cardiomyopathies, such as hypertrophic cardiomyopathy. However, the question is, what about aortic regurgitation? Well, there are no cases of aortic regurgitation in these studies. And I'm sure that you can tell me, well, aortic regurgitation is not a diagnosis that is made at the postmortem, but is a diagnosis that is made at the echocardiogram or cardiac MRI in the living individuals. That is definitely true. However, the proportion of cases with an isolated abnormality of the aortic valve was very low. So there were some cases, for example, in our series of bicuspid aortic valve. In some of these cases, there was aortic stenosis, but there was no hint of aortic regurgitation. And I want you to focus also on this recent studies published on the Journal of American College of Cardiology just a couple of months ago. This is a study on adolescents who die suddenly. Among valvular heart disease, the most common conditions were mitral valve prolapse, just 9 cases, and aortic stenosis due to bicuspid aortic valve, just 8 cases. So it's a minority in general. We don't know too much if valvular heart disease has a causative role or it's just an innocent bystander. But clearly there is no suggestion that there are significant abnormalities in a high proportion of patients. So I think I convince you that intense exercise is not likely to trigger serious arrhythmias in aortic regurgitation, because moderate aortic regurgitation is not an arrhythmogenic disease. What about the second point? Intense exercise may worsen the underlying condition. And I think we need to take a step back into pathophysiology. So as we all know, in aortic regurgitation, there is a backward flow into the left ventricle during diastole. And this eventually increases the LV volume through an increase in the preload. We have increase in LV mass, LV systolic dysfunction, and LV failure. Aortic regurgitation causes also increase in stroke volume and increase in systolic blood pressure, which would eventually result in increase in afterload. And I think it's important to remember a couple of important pathophysiology laws in this context. One is the law of Laplace. LV wall stress is related to LV pressure and radius. There is an inverse relationship with LV wall thickness. So the more the LV pressure caused by AR, and the more is the radius of the left ventricle caused by increased preload, the more is the LV wall stress. And then the second law is the Franz-Starling law, where there is a relationship between the preload and the stroke volume. But in this context, is exercise good or bad in AR? Again, we don't have randomized controlled trials in humans, but we have randomized controlled trials in animal models. Again, this is severe aortic regurgitation, so it's something slightly worse than what we are discussing today. But I think it's important to reflect on this data. Again, animal model, 3 groups: sham sedentary, 40 cases, severe AR sedentary, 80 cases, severe AR trained, 40 cases. Training consisting in treadmill running for up to 30 minutes, 5 times per week for 9 months, the maximum speed of 20 meters per minute. So I would say that this is aerobic exercise, it's not too intense, it's dynamic exercise. What did the author found? After 9 months, 65% of trained animals were alive compared with 46% of sedentary ones. And this was a statistically significant difference. There was also significantly less fibrosis in the train group, and lower LV filling pressures, and improved echocardiographic diastolic parameters. So the conclusions of these authors that in animal models of severe AR, exercise, aerobic exercise, seems to be beneficial. And this benefit is in the form of survival, but also in the form of enhanced hemodynamics, diastolic function, and also less fibrosis. However, I think that we should reflect on possible issues related to intense exercise in AR. I will say two main issues. The first is the reduction in heart rate, which is typical of athletes. The second is the increase in afterload, which is typical of some forms of static exercise. Let's start from the reduction in heart rate. Reduction in heart rate causes an increase in the diastolic time. We know that the systolic time is quite fixed. Instead, what changes is the diastolic time, and it changes with heart rate. The more the heart rate, the less the diastolic time. The lower the heart rate, the higher is the diastolic time. The hypothesis for many decades was that the more the diastolic time, the more the aortic regurgitation. As I said, this theory has been out there for decades. And this is a study from more than 50 years ago, published on Circulation. This is a study on a human model where the authors compared the hemodynamics of aortic regurgitation in normal sinus rhythm and in natural pacing. And what they found was that when patients were subjected to atrial pacing, the end diastolic volumes, the end systolic volumes, and the end diastolic pressures, as well as the stroke volume, were lower than in normal sinus rhythm. So the conclusion was that the lower the heart rate, the worse the aortic regurgitation. This theory has been challenged in the last couple of decades by several studies, I would say. I just mentioned one of them. These studies were mainly focused on the effect of beta blockers in aortic regurgitation, because, of course, one of the possible results of the theory of the lower heart rate, the more the aortic regurgitation, is that beta blockers with their chronotropic effect would be detrimental for these patients. But as I said, few studies show something very different. This is one of them. This is not a randomized controlled trial, but it's an observational study on patients with aortic regurgitation who were on a beta blocker and patients who were not on a beta blocker. And the authors found that patients who were on a beta blocker had a better survival than the ones who were not on a beta blocker. What about the increase in the afterload? So aortic regurgitation causes increase in stroke volumes, increase in systolic blood pressure, and increase in the afterload. Interestingly, increase in afterload causes an increase in aortic regurgitation. This is a vicious circle. So the more the afterload, the more is the AR. Just as a reminder, afterload is the resistance the left ventricle must overcome to circulate blood. Instead, preload is the volume of blood in ventricles at the end of the diastole. And we've seen that there is a relationship between preload and stroke volume. Traditionally, some type of exercise, typically static exercise, have been associated with an increase in afterload. Instead, dynamic exercise have been associated with an increase in preload, especially of the right ventricle, but also with a decrease in the afterload. So someone can say, well, static exercise, patients with aortic regurgitation, increasing afterload due to static exercise, worse aortic regurgitation. I would like to share with you this, I think, relatively small study, but with quite interesting results. So the authors investigated 23 asymptomatic patients with AR. The LVF was more than 50% in all of them. And these individuals had a resting and static exercise CMR. What do I mean by that? The participants were asked to lift both legs to an angle of 45 degrees, and they were asked to keep that position for 10 seconds. They had a weight there, and they were encouraged to keep the maximum weight until they were able to. And then, of course, the cardiac MRI sequences were done, the images were acquired. So the interesting result is that static exercise, so of course the authors compared AR during exercise and at rest. And so during static exercise, the AR volume decreased. This is counterintuitive. Why? Because of course, as I mentioned before, if we have an increase in afterload, that has to, in some way, result in an increase in AR. Instead, in this case, AR volume decreased. Why? Because stroke volume, LV stroke volume decreased, and that led to a decrease in AR volume. But why did the stroke volume decrease? Because the preload decreased. And the preload decreased because there was an increase in intrathoracic pressures. Intrathoracic pressures increased because all of the athletes exercised some kind of Valsalva maneuver, which is typical of static exercise, or most of static exercise. So Valsalva maneuver, increasing intrathoracic pressures, decreasing preload, decrease in LV stroke volume, decrease in AR volume. Okay, so paradoxically, the static exercise decreased the AR volume through this mechanism. The conclusion of the authors that perhaps the effect of static exercise on afterload is overstated. And this was shown before on a model of athletes, and not necessarily individuals with aortic regurgitation. In this study, the authors demonstrated that leg press exercise performed with a brief Valsalva maneuver is not associated with an alteration in LV wall stress or LV systolic function in healthy young men. And this leads me to my take-home messages and my conclusions. So exercise has not been proven to be deleterious in moderate AR with normal LVF. Autopsy series of sudden cardiac death in athletes have shown rarely cases of aortic valve abnormality or aortic valve regurgitation. Animal models, interestingly, have shown a possible beneficial effect even in severe aortic regurgitation model of aerobic dynamic exercise. Significant bradycardia possible after load increase, especially in athletes engaging in static exercise, may not be sufficient to explain a deleterious effect in individuals with moderate AR. Why? Because the effect of heart rate, lower heart rate on aortic regurgitation have been challenged in the last couple of decades, and because static exercise does not mean necessarily only increase in afterload, but there is also a decrease in preload, which has an effect, actually a beneficial effect, on aortic regurgitation. Thank you very much for your attention.
Thank you, Gerardo. What an excellent talk. Now, it is my absolute pleasure to introduce Dr. Michael Papadakis, consultant cardiologist at St George's Hospital in London. He is also the president for the ESC Preventive Cardiology, and he will be speaking on the against argument that any exercise is possible in moderate aortic regurgitation with a normal ejection fraction. Michael.
Good afternoon, ladies and gentlemen. I would like to take the opportunity to thank the Institute of Sport, Exercise and Health, and in particular Dr. Sabiha Gati for the kind invitation. I support the charitable organization Cardiac Risk in the Young, but there is no particular conflict of interest related to this presentation. Now, I've got the contra aspect of the debate, whether any exercise is possible in athletes with aortic regurgitation. And I've got a bone to pick here with Dr. Gati. Firstly, because he puts a theme of David versus Goliath, and given my size, my relative seniority to Dr. Finocchiaro, and the fact that I go second in this debate, I assume I represent Goliath, and we all know what happened to him. But I can reassure you that today history is not going to repeat itself. The second aspect is the fact that the 2020 ESC guidelines, which form essentially the gold standard for practice of sports cardiology, state clearly in this table that in individuals with moderate aortic regurgitation, participation in all competitive sport, if desired, should be considered in those who have a normal ejection fraction, which is more or less the title of this particular debate. That puts me in a bit of a difficult position, given the fact that I am an author of those particular guidelines. And not only that, but we've written a recent review for the Heart Journal discussing exercise recommendation in individuals with heart disease. And you will note that in terms of moderate aortic regurgitation in the yellow box here, we recommend all sports and exercise. However, it's important to note that this is subject to certain parameters. And both the ESC guidelines, as well as our review article, states that those individuals, in order to be able to participate in any exercise, aside from having a normal ejection fraction, they need to have a normal left ventricular size, a normal or only mildly dilated aortic root, and a normal exercise test. So my response to the debate is that any exercise may be possible under the right conditions. And those conditions, aside from the ejection fraction, include the size of the left ventricle, the size of the aorta, the functional capacity of our athlete, as well as the absence of exercise-induced arrhythmia. And only when all those parameters are fulfilled, the athlete will potentially participate in any exercise. Now, rather than presenting you with data, which are pretty scarce in this area, to be completely honest with you, I thought I will make the point and win this debate with an actual real-life example. So I'm presenting to you a 31-year-old male who is a competitive triathlete competing at international level, exercises up to 16 hours per week. He attended a cardiac screening where he was found to be asymptomatic. There was a family history of a sudden death in a young first cousin, but we couldn't elicit anything more than that. And on clinical examination, there was a diastolic murmur. Now, we usually do a 12-lead ECG during our screening, and you will note that he's in sinus rhythm. The heart rate is just above 60 beats per minute, which you may argue is a bit high for that sort of level of athletic individual. He's got voltage criterion for left ventricular hypertrophy and no other abnormalities to note, perhaps aside from fulfilling the voltage criterion for left atrial enlargement based on that biphasic P wave with a negative phase which is one small square deep and one small square wide. On transthoracic echocardiography, however, he had, as you can see, a dilated aorta with what looks like a dilated left ventricle with a normal left ventricular contraction. Now, the closure line of the aortic valve looks fairly central, to be honest with you, but you will note on the color flow that there is a highly eccentric jet of aortic regurgitation that hits the anterior leaflet of the mitral valve. And if we go to the short axis view, then you will note that there seems to be fusion of the left and the right coronary cusp. So we've got a bicuspid aortic valve with no rough in between. And on the color flow, again, you note that there is a highly eccentric jet that looks more significant compared to the long axis view. It's also worth noting, because bicuspid aortic valve can be associated with other congenital abnormalities, that the origins of the right and the left coronary are from the normal sinuses. Now, trying to quantify the severity of the aortic regurgitation can be quite challenging in such a highly eccentric jet, so we need to exercise some caution, particularly in the context of a dilated left ventricle. In this particular case, it was quantified as moderate based on a regurgitant fraction of 38%, and the vena contracta and pressure half time for whether it's worth, it also substantiated moderate AR. I'm presenting here to you his 4-chamber apical view and his short axis parasternal view at roughly mid-level, just to demonstrate the dilatation of the chambers, the left ventricle being more dilated compared to the other chambers, with a very dynamic contractile function. And in this particular athlete, the left ventricular end diastolic diameter was 70 millimeters or 35 millimeters per meter square, which is essentially the upper limit of what one may accept as normal in very high endurance athlete, but it's really at the cusp of the upper limit. His ejection fraction was calculated as 50%, which again, one may argue that it's quite dynamic for a high endurance athletic individual with such a dilated cavity. Usually we expect it to be the other way, with an ejection fraction at the lower limits of normal or even mildly impaired. Now, in terms of the aorta, you will note that it is quite dilated, and the sinuses of Valsalva measured 49 millimeters, which is way out of what one will expect for an athletic individual, since athletes may exhibit a bit of aortic dilatation, but usually falls within conventional normal limits of 40 millimeters at the sinuses of Valsalva. Occasionally it may go up to 41, 42, 43, but definitely not 41, which is pathological. We did proceed to further investigations, and we performed a cardiac MRI. And the cardiac MRI can provide more detail in terms of chamber size quantification, which was indeed quite dilated with very high stroke volumes and an ejection fraction of 72%. And the regurgitant fraction of the eccentric jet came back as 43%, which is fairly similar to what we identified on our transthoracic echocardiogram. And it also confirmed the significantly dilated sinuses of Valsalva. We also went on to perform a cardiopulmonary exercise test, and you can clearly see that this is an elite, very fit athletic individual, as you rarely see peak VO2s above 70 millimeters per minute per kilogram, which represented 180% of his predicted. And on ECG monitoring, there was no evidence of arrhythmia during exercise. So if we look at this athletic individual and try to answer the question whether he should participate in competitive triathlons, yes, he does have moderate AR. Yes, he is asymptomatic with a supranormal functional capacity. Yes, there is no exercise-induced arrhythmias. Yes, he does have a normal ejection fraction. If anything, his ejection fraction is hyperdynamic, but he does have a dilated left ventricle, as his LVDD is at 35 millimeters per meter square, and he definitely doesn't have a normal aorta, which is actually severely dilated. And if you look at the guidelines, our athlete will fall in the orange box, where the guidelines will recommend only skill sports or low-intensity mixed or endurance sports, which definitely does not include competitive triathlons. So can he continue with competitive triathlon? I hope the answer that you're looking for is no, he can't. And I hope that you'll be concerned both in terms of his left ventricle as well as his aortic size. And although a very young Dr. Finocchiaro at the beginning of his career, not having the knowledge and experience in sports cardiology, may say yes, I'm convinced that a more mature and experienced Dr. Finocchiaro will most definitely say no to competitive triathlons in this athletic individual. Now, very briefly, I wanted to make a few poignant points. Of course, exercise is beneficial for everyone, and of course, we should encourage every individual with cardiovascular disease to participate in regular physical activity and exercise. And I will argue that we need to have a very good reason to go below the minimum recommendations as depicted in this particular slide. That, however, has nothing to do with competitive level triathlons like our athlete was participating in. Now, when you've got an athletic individual with aortic regurgitation, like the athlete I presented, you need to take a systematic approach, which is comprised of 6 steps. Step 1, assess the valve disease, risk factors, and additional comorbidities, the current level of exercise, and address the patient's wishes in terms of exercise level. In step 2, do a good physical examination, which will allow you to clinically assess the severity of the valvular lesion and for any signs of decompensation. Step 3, go through your baseline imaging, and your echocardiography is key in terms of addressing the cause of the valvular lesion, the severity, and its hemodynamic effect on the cardiac chambers, including your aortic size. And in particular case, assessing pulmonary pressures may be important. You may need to go to more comprehensive or more advanced imaging such as cardiac MRI in order to better quantify the chambers and potentially help you with the quantification and the cause of the valvular heart disease. An exercise test is necessary in order to truly assess the symptomatic nature of the individual and the functional capacity, which you can use as a baseline for future monitoring as well. Address the hemodynamic response to exercise and also exclude the presence of significant arrhythmias. Then give your exercise prescription, which needs to be very, very constructed, following the frequency, intensity, type, and time framework, and then follow up through the same procedure. Now, there is a potential role of exercise imaging as well to see how well the ventricle is responding to exercise, but this is not based on evidence at this point in time. Now, this is an example of an exercise prescription based on the FIT principle, so you need to be as specific as possible and provide the individual with examples of both dynamic as well as strength-related exercise that he is able to perform. Now, the problem with aortic regurgitation is that it can have a number of effects on your heart, including ventricular dilatation due to the increased loading conditions, ventricular hypertrophy, aortic dilatation, myocardial ischemia, and also has been associated with the presence of myocardial fibrosis, okay? And we know that all those in extremes can potentially predispose to arrhythmias and even sudden cardiac death in young individuals. Now, the other issue that regular physical exercise and competing at high level is associated with a number of things like adrenergic surges, increased preload in the case of aortic regurgitation, exercise-related tachycardia, but also the chronic resting bradycardia, which could potentially exacerbate aortic regurgitation, And you've got the chronic structural adaptations that can include ventricular dilatation, hypertrophy, and aortic dilatation. And the question is whether the pathological, together with the physiological influences on the heart, can potentially exacerbate the valvular disease, can lead to adverse cardiac remodeling, and eventually lead to arrhythmias and even sudden cardiac death. Now, in terms of aortic regurgitation and myocardial fibrosis as an example, there is some evidence, both in animal as well as patients, that aortic regurgitation can be associated with increased myocardial fibrosis. And although we haven't got any outcome data in these individuals, we do know that myocardial fibrosis, both in physiological as well as pathological circumstances, can be associated with malignant arrhythmias and sudden cardiac death, as well as with deterioration of the ventricular function. The other thing to highlight is that there can be an issue with differentiating between athlete's heart and valvular heart disease. And the athlete I presented to you is a very good example. So, as I said before, left ventricular dilatation, left ventricular hypertrophy, altered left ventricular function, and aortic dilatation can be the manifestations of both athletic adaptation to exercise and valvular heart disease. And maybe 1 + 1 doesn't lead to 2, but it may lead to 1.5, and therefore cause more quicker deterioration, potentially of the valvular function, as well as the cardiac function in athletic individuals with aortic regurgitation. So in conclusion, ladies and gentlemen, of course, all individuals should participate in regular exercise, and we should provide them with very specific exercise prescription, but does not equate to elite competitive sports and high-intensity exercise. In terms of valvular disease, for the majority of individuals with mild valvular disease, there is no restriction to sports. And for the majority of those with severe valvular disease, high-intensity exercise is not recommended, although that should also be individualized. For moderate regurgitant lesions, such as aortic regurgitation, may be compatible with high volume and intensity of exercise, but that needs to be viewed in the context of an asymptomatic individual with good functional capacity, the absence of significant hemodynamic impact in terms of left ventricular size and function, and please do not forget the aorta, and do not forget the unique nature of the bicuspid aortic valve. In terms of evaluation, individuals with aortic regurgitation should have comprehensive evaluation with history and physical evaluation, looking at symptoms and any evidence of decompensation. The echocardiogram is key in terms of assessing the cause and the severity of AR and its impact on the heart and the aorta. An exercise test, or even better, a cardiopulmonary exercise test, will assess symptoms and functional capacity and arrhythmias during exercise. And an ECG monitor may offer further reassurance in terms of the absence of arrhythmias during actual training. And cardiac MRI can help you in terms of assessing the severity of the valvular lesion and also its hemodynamic impact in terms of chamber quantification, but also assessing for myocardial fibrosis. And then you need to provide an exercise recommendation, taking a holistic approach with a shared decision-making model that takes safety, but also the athlete's wishes into account. What happened to our actual athlete? Well, we discussed his options through an MDT setting, and our recommendation, given the state of his left ventricle, but predominantly the size of his aorta, was for low-intensity endurance sports, while watch and wait. That was option number 1. Option number 2 was to consider a period of detraining and reevaluate to see what happened to his left ventricle, on the understanding that he will still need to continue with low-intensity endurance sports because of the aortic size. And option number 3 was to proceed to surgery. Our athlete decided to take the more long-term review because he was very keen to go back into regular exercise at high intensity and went for an aortic root replacement, where we chose for a metallic aortic valve due to the durability. Now, subsequently, he gradually resumed exercise with the advice to avoid collision sports, and there we've got concerns regarding cycling. And I would like to highlight that although he now participates in recreational endurance sports, he still exercises up to 12 hours per week. And the thing to show you was that his left ventricular end diastolic diameter has gone to 57 from 70 millimeters, despite the fact that he continues to exercise for 12 hours, which indicates that actually the aortic regurgitation was probably more significant than what we had thought. And if you're really interested in the MSc Sports Cardiology and you want to see myself and Dr. Finocchiaro fight it out in different debates, please have a look at our website at St. George's University of London. I rest my case, and I hope I have convinced you that we need to take a very personalized and measured approach, even in individuals with moderate aortic regurgitation. Thank you very much for your attention.
Thank you, Michael. I don't know about the audience, but I really enjoyed both these talks very much. Now we're going to do a 5-minute rebuttal from each speaker, and then I will take any questions from the audience, and we'll also open the polling station so that you can vote. I think the audience will have a hard task voting for one or the other talks, right? Okay, so Gerardo, over to you for your rebuttal.
Okay, thank you very much. I really enjoyed the talk, Michael. I think you make very important points, but I have to admit that you didn't convince me. I think that you made a very important point that clearly someone with cardiac disease, including aortic regurgitation, needs a holistic assessment. The case you presented was very complex. We have to recognize that. And clearly there was aortic regurgitation, but there were many other things around the aortic regurgitation, particularly a very dilated aorta. And also, to be honest with you, I was not convinced about the moderate degree of the regurgitation. I think the regurgitant fraction of the cardiac MRI was quite raised, approaching to 50%. So I think surely the case you presented was complex. There were other things that we needed to consider. But if we consider patients with just moderate aortic regurgitation, I don't think we have any evidence that we can stop or we can discourage these individuals to participate, even at a very high level. I recognize what you said, and I agree that there are certainly challenges in the assessment of the AR, especially in the context of dilated left ventricles, which often can be exhibited by highly trained endurance athletes. However, again, as said, without looking at extreme cases, if the left ventricle is not particularly dilated and there are no other hints of other problems, other abnormalities, again, there is no evidence that we should discourage to participate in high-intensity exercise. You made an argument about myocardial fibrosis, and you said, quite correctly so, that myocardial fibrosis may be a result of aortic regurgitation. That is definitely true. However, where is the effect of exercise on that? We have no idea. In fact, I presented an animal model, not, of course, a study on humans, where in a model of severe aortic regurgitation, exercise reduced the myocardial fibrosis. And we don't have any reason to think that this may be replicated also in humans. I think at the end of the day, we are in a tricky situation because as you emphasize, we don't have trials, we don't have randomized controlled trials on patients with aortic regurgitation, or we don't have randomized controlled trials in most patients with cardiac disease as far as exercise is concerned. So I think That is the future. We should not do trials only on animal models, but we should consider trials on exercise in humans, and definitely both moderate and severe aortic regurgitation patients would be a good fit for such studies.
Okay, thank you, Gerardo. Michael, over to you.
I'm not sure, Sabiha, that I need to do a rebuttal, to be honest with you. I think Gerardo has done the rebuttal for me. And it's clear indication that I won the argument. So if you listen to the beginning of his talk, he talks about just aortic regurgitation. I don't think the debate said just aortic regurgitation. He said moderate aortic regurgitation. And unfortunately, the ideal cases where one thing exists and nothing else exists are quite rare in our medical practice. And the other thing that he said is without looking at extreme cases. Of course, there are the regular cases, but there are the extreme cases that we can use in order to make the argument of the caution that it's necessary in those individuals. Now, there are definitely things that we agree with Gerardo, and that's not surprising because we've been trained and we've worked together and we're very like-minded people. And one of them is that exercise may be possible, exactly as I said in the beginning, but as Gerardo rebutted, it may be possible under the right conditions. So it's not only about moderate aortic regurgitation, you need to look what's causing that aortic regurgitation, what's the underlying valve pathology. A bicuspid aortic valve is not the same as tricuspid aortic valve, because of the fact that we have now understood that it can be associated with aortopathy, for example. So that's something we definitely need to keep an eye. And you saw that extreme example of the athletic individual that I presented. And I'm sure that no one in this group and no one in this audience will be happy for him to continue with competitive triathlons with an aorta of 49 millimeters. So we need to ensure that the hemodynamic impact on the ventricle is not big enough. We need to look at the aorta, and we need to look at the functional capacity in the absence of arrhythmias in those individuals, and then they may be able to participate in any exercise. So my advice is that please do not look at the valve in isolation, look at the entire picture and try and make an informed decision, as informed as possible with the evidence that we've got. And the other very important message that Gerardo reiterated is that please recognize the challenges. Me and him may agree or disagree whether that was moderate or severe aortic regurgitation. It may have been more severe than we thought, but at the end of the day, we're an experienced center that did all the appropriate investigations to try and quantify that aortic regurgitation. And based on the numbers and what we're looking for, we couldn't quite convince ourselves. Why couldn't we convince ourselves? Because we're talking about an elite triathlete with a peak VO2 of 75 mL per mil per kilogram. Okay, that's highly unusual. And these will be the individuals that may exhibit the 65 and the 70 millimeters of left ventricular diameter. Otherwise, we will have to figure it out. Now, a couple more points to pick up on what he said is about the post-mortem. I'm not going to argue that aortic regurgitation is a major cause of sudden cardiac death in athletic individuals, but I think it's misleading to say that we are able to identify it at autopsy and at post-mortem. I suspect that most athletic individuals who have significant aortic regurgitation that impacts the ventricle may be identified with idiopathic ventricular hypertrophy, dilated cardiomyopathy, a dilated aorta or fibrosis. So I'm not sure how you go about identifying aortic regurgitation post-mortem. And the other thing, obviously, that you have noticed is that I didn't present you many study after study after study, because I felt that that would be misleading, as it was partly the presentation that you got from Gerardo in terms of, yes, there are studies that we can present in animal studies, in people who lift their legs during an MRI scan. But those don't necessarily, they reflect some principles, but they don't reflect what happens in an elite triathlete like the individual that I present. So all I'll say is I think we agree, and I'm definitely a very liberal approach, take a very liberal approach to my athletic individuals and athletic individuals with pathology. But I'll suggest that we need to exercise caution, particularly for those who participate in the higher echelons of sport. Thank you very much.
Thank you, Michael. Okay, whilst we're waiting for some questions from the audience, maybe perhaps I'll ask a couple of questions. So I agree with you, actually. I've not seen cases of just isolated moderate or severe aortic valve disease. I've often come across patients who've got dilated ventricles or dilated aortas. Now, what's your practice in terms of managing these people? Do you, they often come with sinus bradycardia, so it's difficult to put them on beta blockers. Are there any other drugs that you would prescribe your competitive athletes or even your recreational athletes whilst you're monitoring them for aortic regurgitation and or aortic enlargement? Michael?
For the majority of them, I will not consider any medication because we've got very little evidence to suggest that the medication is going to make a difference. So I think the important aspect is that you investigate them as comprehensively as possible. You recognize the challenges of differentiating what's physiology, what's pathology, because it's a very, very common mistake that even an aorta of 45, 46, 47 can be attributed to athletic adaptation to exercise, and it's important that we recognize that. And the same goes for the ventricle. So we can't go like a pendulum. We have to find a balance. So we cannot have pathology that we attribute to physiology or physiology that we label as pathology. And that's why it's important in cases, particularly in the most elite of athletic individuals, where your decisions are also likely to have the greatest impact, that you consult with colleagues. And that's why in our institution we've got our MDTs where we collaborate obviously with Gerardo and with yourself from Brompton and St. Thomas's and try to come to a decision in terms of the management of that particular individual. And I think that's important for the athlete, given the limited evidence base. And I think it's also important for the doctor, because at the end of the day, you're going to make a decision based on limited evidence, and it will be nice to have views and a consensus from other experienced colleagues.
Okay. Now, you both talked about echo and cardiac MR. What's the best imaging modality? What would you go for?
Answer that.
Well, I mean, it's difficult to say. I think personally, I rely more on the echocardiogram. But of course, I mean, I think it depends quite a lot on the center and the ability to do MRI. I mean, clearly MRI can help in the assessment. But I mean, as a personal preference, I rely more on the echocardiogram, I have to say.
I agree with that. I mean, I think the echocardiogram forms the gold standard for valvular heart disease, but I have to say that I have started using more MRI. I'm not an MRologist as such. I'm a clinician who uses MRI, so you'll probably be able to offer us a more informed opinion, Sabiha. But I think what the MRI does for you, it gives you a very accurate assessment of your volumes in terms of your left ventricular size in this particular case. And I think that's particularly important as well for follow-up studies, because sometimes you don't get the clue on the day, but you get it 3, 6 months or a year down the line, that was your baseline and that's how it changed. The second one, it can give you potentially more accurate estimation of your ejection fraction. But the third one and more useful is, you saw that jet, how eccentric it is. I'm not sure how reliable even the echocardiogram is in estimating the severity of that aortic regurgitation. And again, I do recognize that the MRI has its own limitations, and I'm not the best person to discuss those. But cutting your aorta higher up and try to identify what's going forward and what's coming backwards is probably a better way of estimating in such challenging cases the volume of aortic regurgitation compared to transthoracic echocardiography.
I would agree, and we can always do a 30-minute scan without the contrast, so we can,
and you potentially can get, because as we said, there are other associations as well. You could potentially have a look at your coronaries, and you can have a look at your aorta in terms of following it up, because obviously the echocardiogram has its limitations, and you can see if it's an isolated dilatation of the sinuses of Valsalva, or if there is something else further down the line.
Now, one thing you both touched on was LV dilatation, one secondary to athletic training and the other due to aortic regurgitation. It's really often, as clinicians, we often find it really difficult to differentiate whether it's the AR causing it or whether it's the athletic training. Do you both go by index values? What's your practice? Maybe
Shall I start? Index values. I think your question is related to what kind of index values, or what do we scale for, or?
Do you use the current index values of less than 35, or do you look at the absolute volumes? How do you work it out, whether it's the AR causing it or whether this is all part of athletic training? When should the clinician be worried that this is adverse remodeling from the AR?
I think, of course, using index values certainly is a good practice, but I think probably, as both our talks alluded to, I think it's important to have a little bit of holistic assessment. I think it's really important to start from clinical information. So, for example, in terms of the dilatation of the left ventricle, surely athletes may exhibit some LV dilatation. Can this be due to aortic regurgitation? We have to really make sure that we understand very well what type of exercise the athlete does, what is the amount of exercise. Is it like a real athlete, or is it like just a recreational athlete who does not do a lot of exercise? All these kind of things are important in the assessment. And then, of course, the other possible determinants of LV volumes in this context, like, for example, body surface area, type of exercise, and all these kind of things. So I think that to try to answer the question, we have to start from the basic and look at physiological adaptation to exercise first, and then try to think if the dilatation is explained by the things that I've just mentioned. And if things, are not fully explained, then we have to think that perhaps we are underestimating the AR, which is a possibility, as Michael said, and it's not unusual.
I completely agree with Gerardo. You need to take a holistic approach with a very practical way. The things that worried me in this individual were the following. One, look for symmetry. If you've got a symmetrical dilatation, so your left or your right ventricle looks asymmetrical compared to the dilatation of the other chamber, start thinking about pathology. It's highly unusual to have a very dilated left ventricle with a normal right ventricular size, or the other way around. The second thing that worried me a bit, and I alluded to, is that he had an ejection fraction of 70%. He actually had a hyperdynamic ventricle. Now, usually what we expect to see in those individuals is the echocardiogram that I showed you in that Venn diagram that I had of athlete versus aortic regurgitation. So yes, they'll have very dilated ventricles, but they will have a resting bradycardia. And because of the resting bradycardia, the increased stroke volume, you're visually, and when you measure it, your ejection fraction may be in the area of 45 to 50, 55%. It's not going to be 70%. So that's why my thinking was, am I underestimating here how much aortic regurgitation do I have? I have to be honest, however, and say that if you look, so his last echocardiogram, his ventricle definitely shrank, so we're probably underestimating things, but his function remained fairly dynamic. Now, is that a feature of that athlete? Does it indicate that there has been some damage there, that it's not going to go back completely to normality? I'm not sure, but those are the features that you need to look at on your transthoracic echocardiogram.
Last question. So you alluded to doing CPET testing. What if the clinician doesn't have CPET available to them? Can a bog standard treadmill exercise treadmill analysis be okay for the assessment of these people?
Yeah, to be completely honest with you, it's not based on evidence. What I'm trying to do, and as I said in my evaluation, you try to do fairly simple things. Look at the functional capacity, ensure that he's truly asymptomatic, exclude any significant arrhythmias, and potentially look at your blood pressure response to exercise, which you can do with a treadmill. Now, Personally, I do use a cardiopulmonary exercise test, either a treadmill or a cycle ergometer, depending on what the athlete does, because I think it's a better representation of the activity that they do, and you can get them to their maximum. I'm not sure you can necessarily achieve that with a Bruce protocol, for example, which was designed for something completely different. But most definitely an exercise test, if you don't have a cardiopulmonary exercise, which is very common, particularly in the United Kingdom, should be absolutely fine.
Thank you both. Let's have a look at the voting. Let's see.
Don't tell me that Goliath fell.
I believe Goliath has won.
Ah.
But excellent talks either way. Thank you both.
Congratulations.
Fantastic. Thank you very much, and thanks for the debate, Gerardo.
Thank you. And thank you, Sabiha.
Thank you. I would like to thank the audience for participating in this conference. I would also like to thank all the speakers. There were excellent talks. I'd also like to thank the people behind the scenes, Kelly and Craig, for their relentless work and organizing this conference for us. I hope you will join us next year again. Hopefully it will be in person, if not a hybrid type of a session. And I look forward to catching up with you all very soon. Have a great evening.